So I want to begin by welcoming everyone on behalf of the Nova Scotia College of Social Workers to our Big Ideas in Mental Health panel. This month, we are going to be focusing on issues related to Black and African Nova Scotians. And I want to take this moment to begin by acknowledging that I am speaking from Mi'kma'ki. And indeed, the Nova Scotia College of Social Workers is located in Mi'kma'ki, which is the ancestral and unceded territory of the Mi'kmaq, whose inherent rights were recognized in the peace and friendship treaties that were signed from 1725 to 1779. This series of treaties did not surrender Indigenous land, resources, or sovereignty to the British Empire, but instead established rules for an ongoing relationship between nations. The treaties were later reaffirmed by Canada in Section 35 of the Constitution Act in 1982, and they remain active to this day. The Nova Scotia College of Social Workers joins our members and our communities in the necessary labor of reconciliation. We are grateful to live and work together as treaty people in Mi'kma'ki. Please think of the lands, territories, and Indigenous peoples who lived and continue to live within these lands, and how each of us individually and as a collective body of social workers can hold ourselves accountable to reconciliation with Indigenous peoples here and across Turtle Island. We are all treaty peoples. Wulaliu. Thank you all. I also want to take this moment to recognize the 400+ year history of communities of African descent and the 50 African Nova Scotia communities throughout the region today. We take this opportunity to affirm our belief in advancing Indigenous sovereignty is deeply and inextricably linked to Black liberation. We remain committed to advancing both. We commit ourselves to continually learning more about how we can engage and move forward the work of truth, reconciliation, and equity for all people. We recognize that without action, all acknowledgements are empty. It marks the beginning of the work ahead of us, not the end. I also want to take a moment to thank our Social Justice Committee. Big Ideas in Mental Health is a special program organized by our Social Justice Committee as an opportunity to rethink some of the major social justice issues impacting the mental health of Nova Scotians, and to invite new and creative ways of thinking that challenge assumptions and opens us up to new solutions. And I want to take a moment now to make a special thank you to Juanita Paris, our Social Justice Committee member who organized today's panel. Thank you so much. And of course, thank you to our panelists. One of our panelists had to drop out at the last minute, but we are so grateful to both Mario and Dr. Waldron, who have agreed to come and join us for this lunch hour. Dr. Waldron, many of you will remember, spoke at our first annual awards gala event, and we are so grateful to welcome her back. She is known to many of us as Professor and Hope Chair in Peace and Health, Global Peace and Social Justice at McMaster University, but of course has a long history of time here in Nova Scotia, and we are so grateful to have her with us. And Mario Rolle is a member of our Social Justice Committee, and he is, amongst his many other awesome talents and skills, co-founder and co-producer of My Melanin podcast. And with that, I am going to stop screen share, and I am going to invite Juanita to, I'm going to spotlight her so everyone can see Juanita, and I will invite her to lead us in our panel. Thank you all.
Yes, good afternoon, everyone. Thank you for all taking your time to join us, and happy African Black Heritage Month. This is a special month for African Nova Scotians and people of color. So This is a great month to do this. I'd like to thank the panelists, Dr. Waldron and Mario, taking out your time. I know you're both very busy professionals. The panel for Big Ideas in Mental Health and is basically addressing the lack of resources within our Black and African Nova Scotia communities. And that's very much of a passion of mine, so we can bridge the gaps in that. And basically what we're going to be doing is looking at 3 questions that we're going to be asking the panelists, and they will respond, and then there'll be questions and answers at the end. The first question is for the panelists, is what do you see as the barriers between Black African Nova Scotian communities and the mental health providers? Dr. Waldron?
Okay, so I guess I'll begin by saying that my responses today are based on 3 studies that I conducted when I was in Nova Scotia. So I'm coming from a research perspective where I'm sharing with you what was said during interviews and focus groups. The first study is called Black Women's Experiences with Mental Illness, Help Seeking and Coping in the Halifax Regional Municipality, a study conducted to inform Nova Scotia Health's Nova Scotia Sisterhood Initiative. So that's one study. The second study is called Your Mind Matters, an African Nova Scotian youth education project, which focuses on Black youth experiences with psychosis and help seeking. And the third study comes from a mental health professionals perspective. Black mental health professionals speak, informing Nova Scotia Health's African Nova Scotian healthcare strategy, which is about the experiences of health professionals delivering services to clients. So to answer the first question, what do you see as the barriers between Black African Nova Scotian communities and mental health providers? Based on the findings from these 3 studies, I would say the major one is a hesitance to reach out to and receive care from mental health providers due to the taboo and stigma around mental illness, personal and cultural beliefs that suggest that those who suffer from mental illness are weak, have lost their way, have a spiritual sickness, should be able to pray it away, and should be able to address mental illness on their own. Next, I would say challenges finding culturally competent counselors was something that was mentioned by participants in all 3 studies. Challenges finding competent counselors who understand the role that race, gender identity, sexual orientation, and other identities play in mental health struggles. This was particularly an issue for the Black women that I interviewed for the study on Black women's mental health. Also discussed was an inability of white mental health professionals to resonate with Black patients since they don't share their experiences as racialized people. Negative experiences receiving services from white mental health professionals who are often dismissive. Challenges finding Black mental health professionals. The lack of cultural competence demonstrated by the health system in addressing the belief systems and needs of people of African descent. The lack of safe and supportive places where Black youth, so this is specific to the Black youth study, where Black youth can go to address their mental health concerns. Hesitance among Black youth to seek help due to a fear of police involvement. The lack of mental health literacy in Black African Nova Scotian communities, that is, lack of knowledge and understanding of mental illness. So that's all I'll say for now.
Thank you.
Thank you.
When I got a question, I started to think about it, and I was like, oh, what are some barriers? And so what I'll do is I'll give some of the things that I experience, I've seen as a frontline worker. I'm a social worker, and I work with high risk. I used to work with high risk men. So, individuals in the street, crimes, and you name it. And so one of the first things that I recognized, or a client came to me, and basically said, you actually look like me. And so the first thing I would say is the providers. Providers don't look like us. All right. A lot of individuals, especially individuals from the African Nova Scotian communities, a lot of them, they somehow end up in the system, and they end up in the system at a young age, right? And so what that means for us is they will potentially see multiple caseworkers, social workers, therapists, doctors. They're going to see tons of them. So if they come into the system, like, let's just give an example at the age of 8, their caseworker, they're going to probably have 3 or 4 caseworkers that doesn't look like them. Dr. Waldron talked about cultural competency. Will that caseworker be culturally competent to understand what a Black family is going through, understand what that little boy or little girl is going through? Right. So that's one of the biggest issues that we face. The second one is relationship. And so what happens when it comes into relationship? Let me give an example. As you go into a clinic, an individual goes into a clinic to see a doctor, right? If, let's say, for instance, this is that individual's provider, which means the individual has seen this doctor for at least, has seen him or her over once or twice. And so what happens is there should be some sort of relationship, right? When you go to rural communities, in particular, let's say a North Preston or East Preston, there's a community-based clinic in the Prestons, which means the providers in those locations would know their clients. Essentially, they would know their clients. When you go into urban Nova Scotia, in particular the HRM, the doctors basically, they come in, you tell them what happened. Most of the time you're given maybe two, you can tell a doctor about 2 issues. Doctor, my leg, no, that's my arm. Doctor, my arm, or I'm feeling sick. After that, basically you're gone. And so what it does for some clients is, you know what? This individual don't want to get to know me. This individual doesn't know what I'm going through. So therefore, why should I go back to see this individual? And so because there's no relationship, it draws clients further away from the healthcare, the mental health care services. When it comes to let's say mental health care services, an individual is referred to see a psychiatrist or social worker. Sometimes, as we all know, the wait time can be pretty long. And so who is the middle person? Like, how is that person gonna get help, or how is that person gonna be encouraged? There isn't anything in there to buffer until that wait period is done, right? I know an organization that does that. It's a Black organization, and I have seen it work where individuals, it's called the Nova Scotia Brotherhood. I've seen where individuals connect with clients, and from there they have a doctor. The doctor sees the client until the client is able to see either the clinical social worker or the psychiatrist. So I would say relationship is important, and also too, especially if we right now in the system, let's even move back further. When we talk about the schools, the housing, the universities, we don't have that much persons of color that apply for these courses, right? So that's one issue, encouragement. How can we push? How can we advocate for individuals amongst these schools or in these schools to advocate or to bring in visible minority people? Also allyship, seeing that this is not happening right now. My question, I wouldn't even answer that question. This question will go back to the audience. How can we help? How can allyship help visible minority communities, right? I know what it is. let's build relationship. But the question would be, how can you help our communities? Thank you.
Thank you, Mario. Thank you, Dr. Waldron, for the first question. Very informative. I think you answered some of the second question that I'm about to state. What do you see as the possible solutions in removing some of those barriers?
Well, through the 3 studies, participants were really specific, actually, about solutions and recommendations for the health system. So just once again, looking at the 3 studies that I conducted, they talked about the need to hire more Black mental health professionals who are diverse based on culture, because in Nova Scotia, of course, we have a Black community that's extremely diverse. You've got the 300, 400-year-old African Nova Scotian community. You've got people from the Caribbean. You've got now people coming from different countries in Africa. So we are Black, but we are culturally diverse. So they mentioned, culturally diverse health professionals, African Nova Scotians, Caribbean, African, but also diverse based on sexual orientation, gender identity, and educational background, and also professional training, meaning you have your social worker and your nurse and your occupational therapist. They want to see Black mental health professionals who are diverse based on social identities, but also diverse based on the health profession that they come from. So they mentioned specifically general practitioners, nurses, recreation therapists, social workers, psychologists, psychiatrists, nutritionists, clergy with counseling experience, therapists and counselors, including youth counselors. Second, they said ensure that these health professionals have expertise in trauma-informed counseling and can support Black and African Nova Scotian people in addressing their trauma histories resulting from intergenerational trauma and systemic discrimination and microaggressions related to racism, homophobia, transphobia, race and gender-based violence, and family and relationship conflicts. Third, I was very pleased to see that some of the participants were thinking in very holistic ways. This actually came mostly from the study on Black women's mental illness, just the kinds of methods that they are actually using, Eastern, Western approaches, a mix of both. I don't think most people realize that Black women are engaged in multiple Eastern practices, all of these diverse practices in order to take care of themselves. So they talked about, of course, that the services needed to be holistic, community-driven, trauma-informed services that combine Western, what we call alternative, and self-care or self-healing approaches. And these approaches needed to consider and address the intersecting personal, social, economic, community, and physical health needs of Black women. The services that they mentioned include any or all or of these approaches: individual counseling, peer support groups, meditation, yoga, mindfulness, emotional freedom technique, acupuncture, art therapy, music therapy, healing services, and sound baths, but there are like 10 more. There was a long list. They also mentioned that there's a need to ensure that mental health services offer a safe space for Black women from the LGBTQ community, support Black communities in developing cultural literacy around mental illness, ensure that all services are offered at no cost or are covered by insurance. And this is, when I said that the services need to address people's personal and social circumstances, so this is kind of addressing the issue of low income. Not everybody can afford to see certain mental health professionals. So they wanted the services to be offered at no cost or covered by insurance, offer services through voice video chat for clients who are unable to attend services in person because of work, childcare, and other responsibilities, offer training and education to church ministers and other spiritual leaders about ways to support Black African Nova Scotian people who are experiencing mental health struggles. Of course, the church is extremely important for Black communities worldwide, and certainly spiritual counseling takes place in the church. But they wanted the ministers to be a lot more culturally competent, since that's where a lot of people get their counseling support from, and wanting them to be trained as well. They wanted someone to form a youth advisory committee that can organize and hold educational sessions on mental illness for youth. So that came out of the youth study I did. They wanted a group formed comprised of Black and African Nova Scotian mental health professionals, youth workers, and individuals from Nova Scotia Health that can hold sessions on mental health in Black and African Nova Scotian communities. Develop creative tools to share information about mental illness, such as an app, videos, plays, art, music, television ads, educational commercials. Share information about psychosis and other mental illnesses in the Black African Nova Scotian community through Bell Let's Talk and other media campaigns. Create a list of Black mental health professionals in Nova Scotia that can be shared with the Black community. I think this is really important because when COVID hit, I was at Dalhousie at the time. And of course, we were all struggling in terms of our mental health, but students were struggling, and Black students were kind of reaching out to find mental health professionals, particularly those who are Black or people of color. And we didn't have a list. And I got my research assistant to develop a list of available services being delivered by Black or people of color. And that was given to the Black, the BSAC, the Black Student Association. But it was something that I just kind of developed on the whim. And it certainly wasn't enough, but I think now we have a larger list at Dalhousie where we just point Black students to. So I think for the Black community to have a list somewhere, maybe the African Nova Scotian directory, where they can access very easily a list of Black mental health professionals or people of color who are delivering services. So I think that list is really important to share. And that's all I'll say at this point in terms of practical recommendations.
Thank you so much. And
Thank
I
you,
just,
Dr. Waldron. Sorry,
I just wanted to say, because I've gotten a lot of questions in the chat, many people are eager to see Dr. Waldron's research studies that she's referencing. So hopefully she will send that to me and we will include it in our follow-up email to everyone. So
Sure.
have no worries. People are very eager to learn more. Thank you so much. And now I'm going to invite Mario to
welcome back, Mario.
Thank you. This is one thing on the side. I don't like to go after Ingrid Waldron for any reason, but let's put that out there. She's one of my best friends. So to answer the second question, I'm going to hit on some of the things that Dr. Ingrid talked about. Hiring more providers from visible minority groups is one thing that stands out to me, right? People always ask, what can we do? How can we help? Listen, how you can help. How you can really help is hire people that don't look like you. Have uncomfortable conversations, right? That's the first thing I would say. We talk about creating culturally competency programming, right? Creating it within various structures, not just community-based, not just for the social workers, right? For me as a social worker, this is something that I haven't really learned in university. I didn't learn about being culturally competent in university. That's something that's innate, right? I learned about being culturally competent outside in community. So having potentially having community groups come within university structures and talk about what culturally competency is, right? When it comes to schooling, right? There needs to be almost like a hybrid model where students can interact with community-based organization, right? Because what I've seen is this. I've seen students come from high school, get their first degree, they go into their bachelor. I'm not speaking on behalf of like social work. They will go into their social work course and potentially finish their bachelor's, do their master's, and then they go into the field. Sometimes what happens is, the expectation in their mind is, I'm coming to save the world. And then when they get out there, they see a total different world. And then all of a sudden they quit, they give up. right? And so I feel too, there needs to be some hybrid model when it comes to, when we talk about culturally competency, we need to provide more action, right? We need to provide more action. Okay, what does this look like? I've heard it years and years and years. Culturally competency, cultural competency. What does it mean? How can we implement that? Right? We need to start implementing. We need to start do. Right? The second thing, more education and mental health. Some of the barriers is this, right? We got the professionals, we got the team leaders out there who can do this work. Some communities don't really know about mental health. Mental health, Dr. Waldron mentioned it earlier. It's taboo in some communities, right? And so when you talk about mental health, people shut down. When you use the term mental health, people shut down. So how do you make it culturally competent to suit various communities? For me, when I talk to individuals that look like me, I say, let's have a conversation. Let's have a healthy conversation, right? And then we move from there, right? Once individuals see, like, especially when it comes to individuals who are white, right? What we see is we put health professionals on a pedestal, right? When we put them on a pedestal, it's almost like this. Okay, this is a doctor. The doctor's always right. Whatever the doctor says is gospel kind of thing, right? We don't know. So I feel like there should be an educational component where we can go and teach community about their self. So when a client, a patient comes in to see a provider, they can advocate for their self. They can't advocate for themselves if they don't know what's going on. So I feel like when it comes to creating this cultural competency or even providing education around mental health, we gotta educate our people so that they can be advocates for their own health. All right. Dr. Waldron also talked about a sisterhood. I'm hearing that a sisterhood is coming. That's what I'm hearing. Right. This is big. Why I say it's big is because of this. I see what the Nova Scotia Brotherhood is doing, right? They're providing health and mental health care for men of African ancestries, right? There are tons of reports and research out there on women's health. Dr. Waldron stated two already that she worked on, right? And so it's clear that it's imperative for us to talk about or visit this Nova Scotia sisterhood. What can we do to prevent barriers? People of Eurocentric views, or white people, get more involved in visible minorities healthcare, right? Get more involved, become an ally, right? What does that look like? The same issues that a white woman may have may be different from a Black woman. The same thing as a man. Educate yourself, right? The same way how we educate ourselves on different culture, we educate ourselves on diseases, mental health issues. Let's educate ourselves on the various visible minorities as well, and find what are the needs, right? People would always come to me and ask me questions, right? Before I answer them, I would ask them, did you Google it? What did Google say? Right? If you can't find it, did you look it up? And then when you already looked it up, let's have that conversation, right? The last thing I want to talk about is I'm hearing about a Black health strategy. That's the next thing where we can bridge the gap, right? Where there is a group that focuses on Black health, Black mental health. In Cape Breton, there's a health authority that's I think I'm not sure if it's launched already, but there's a health authority for the Indigenous our Indigenous family, brothers and sisters. There needs to be something for the African Nova Scotian and the Black community. So that's what I feel can help when it comes to removing various barriers. Thank you.
Thank you so much, Mario. So appreciate it. The last question is, what could social workers, as well as other health providers, do to advocate for change in bridging the gap between Black African Nova Scotians and the province mental health services?
Yeah, so once again, my responses is from the voices of the communities that I engaged in my study, so it comes directly from them. So first thing that I'm going to talk about is funding. So what was mentioned was funding support. Funding to support activities that help foster relationships and partnerships between Black people and community-based organizations that can support them, specifically because we don't want to let the health system off the hook, of course, but many community organizations, Black community organizations, as I mentioned earlier, churches or faith-based organizations are providing counseling support. But as I mentioned, they're often not trained to do that. But for a lot of Black individuals, their social and cultural and health needs are often supported by organizations in the community, Black organizations. So providing funding support to foster those relationships is something that was seen as important to some participants. They also talked about hiring someone who is specifically taking care of advocacy around mental health. So hiring an African Nova Scotian mental health advocate in the healthcare system. We don't have that. Mario just mentioned the African Nova Scotian healthcare strategy, which I was a part of. I was on the committee. We suggested that they hire the first African Nova Scotian manager, I believe. And about a year later, Rhonda Atwell was hired, and that's the first time ever, right? First time ever. So she is taking care of everything that has to do with health for Black people in the province. And this is a major achievement, first time ever. But I'm talking now about specifically mental health, and I'm talking about an advocate. Rhonda is not necessarily an advocate. She's just she's a health manager. So we need somebody who's an advocate, who's going to advocate specifically around mental illness for Black communities and Black families that are dealing with mental health struggles. They also talked about, of course, we talk about this all the time, increased representation of Black people of diverse backgrounds at all levels of the healthcare workforce or the healthcare system. So of course, we talk often about, yes, the health professionals need to be representative of the community, but we're also talking about policy making. When I did my research on Black mental health professionals, I was very surprised that when I was trying to recruit participants, I didn't find any policy people. And I spoke to somebody and I said, well, where are the policy people? Because I'm getting the clinicians, I'm getting the psychiatrists and the therapists. And the person said to me, that tells you, Ingrid, that there are no Black people really working in policy at Nova Scotia Health. I was very surprised. I guess I was naive, because I was looking for, I think, 20 participants from each category, 20 clinicians, 20 policymakers, and 20 professors. 20 professors at a university, so I can get different perspectives, right? The research perspective, the clinical perspective, and then the policy perspective. I fell a bit short with the professors, which tells me as well that there are very few Black professors working around mental health in the province. But I was stunned by the fact that I think I got no more than 5 Black people who were policymakers across the province. So I didn't know. So we need more Black people at all levels of the health system, as well as on boards, right? The people who are on those boards, they are the ones who are making decisions. And that's sometimes the most important place to be, is the people who are making policy decisions. And if we don't see Black people in those positions on boards, then the decisions often will not consider them because it's coming from a particular perspective. Another great idea was pathways for Black African Nova Scotian people who are interested in becoming health professionals by helping them to develop relationships with healthcare professionals for mentorship and guidance. So in Dalhousie, there is plans. I always forget what it means, but they bring Black high school students to campus so they can explore various health professions like OT and nursing for a week. It's been extremely successful. So that is a pathway program where you kind of create awareness among high school students who are Black about future careers. It's been extremely successful, but I'm talking a little bit more than that, to provide much more intimate mentorship for Black students. So it creates a pathway for them to get to know people in the healthcare system, once again, get guidance and mentorship and explore opportunities within Nova Scotia Health, so that it engages them in these careers, so that they choose these careers in the future. Retention policies was also mentioned, retention policies and incentives to retain Black and other racially and culturally diverse people in the healthcare workforce, because the representation is so low, and many of them are often dissatisfied in terms of discrimination going on in the healthcare system, in terms of how hard it is for them to get promoted. We could lose them, right? It's very easy to lose them if they're facing discrimination on an ongoing basis, direct forms of discrimination, but systemic discrimination where, and I've spoken to some of them where they've tried to get higher level positions and there are always barriers. So how do we create retention policies and incentives to retain the very few Black mental health professionals that we have in the system? They also talked about mental health policy that acknowledges the experiences and mental health needs of Black, African, Nova Scotian people who are diverse. Policy is everything. Policy is the decisions that you make that actually shape services. Policy is where everything starts. So if we don't see culturally competent services, if we don't see representation of Black people in various positions, it's because of policy. So that's where it starts. So that means that we have to intervene at that level, specifically with mental illness, a recognition of cultural competency in mental health policy, and the need to look at diversity within the Black community, but not diversity in the typical ways, but in the ways that I mentioned earlier. Black people are very diverse based on gender identity, sexual orientation, and Black people want to see people who are like them, not the same, necessarily just the same color. But if you are somebody who's gay or you're trans, it's perhaps somebody who is also trans and Black is somebody that would be better able to engage that population because they understand the experiences. So yeah, we need to kind of open up our understanding of diversity when it comes to Black people. We are not all the same. We are not a monolith. We have various social identities just like everyone else. And finally, mental health policy that includes evaluation methods that identify and include key measurable indicators for ensuring that cultural competence is being practiced. Thank you.
Thank you so much, Dr. Waldron, as well as Mariel. This has been so informative. I so appreciate it. I'm going to hand this now over to Nadia, because there'll be some Q&A.
I think actually it's still Mario's turn. So,
I'm sorry, Mariel. I apologize.
Yeah.
I thought you had.
No,
I'm so sorry.
She's trying to run away from me. That's fine. That's fine. But
not at all, Mariel. Not at all.
But Ingrid, she did touch on policy makers. I just want to add a few other stuff to that. She hit everything, and I appreciate that. Management. One thing I didn't hear too much on is management. We need to start, as social workers, we need to start advocating for management, people in management to reflect sometimes some of the employees. Let me give an example. As an employee of Nova Scotia Health, when I first started, I hadn't seen people who look like me or reflected me in management. And some people be like, oh yeah, that's okay. No, it's not okay. All right. When we talk about cultural competency, that's like how can someone advocate for you in a position if they don't know what you're going through, right? And so I feel like right now, me person on the outside looking in, I'm advocating for management. I'm advocating for more people of not just Black, but visible minority to be in a position, not just lower management, but upper management. When Ingrid talked about policy, like in order to make change, you got to be a part of that policy making a community, right? So in order to change some of these things, we need to be a part of that policy, be a part of policy decision making. I also think about collaboration. When I think about frontline workers, social workers, a lot of social workers, and also therapists as well. A lot of them, they don't want to go in communities. They want clients to come to them, right? They don't want to go to clients. Like they don't want to go in East Preston and meet with the client. And so what happens is when you take an individual out of their community, a barrier itself is created, and especially if there's no relationship. As social providers, we always were taught about meeting individuals where they're at, and so I feel like that collaboration with the Black and African Nova Scotian community is imperative. Even if you're not Black, right? So if you, I would say try it. To all of the providers out here, try it. You don't necessarily have to go to their houses. There are churches there are community centers in almost every community. Arrange to rent an office out and meet them where they're at. I mean, and you social distance or whatever, right? But for instance, we're doing this, we're in this age of Zoom, right? And Zoom works sometimes, but you lose focus, right? Where a clinician is talking to a client, if the client is mandated to talk to the clinician, they're going to be there. Their actual body is going to be there, but their mind isn't going to be there, right? But when you have them in person, you'll be able to know if this individual is paying attention to you or understanding what's happening. So I'm not going to hit that too much, but I say collaboration with the communities is important. Creating resources. Ingrid talked about it a little bit earlier. Funding. When it comes to, let me tell you something that a lot of people don't want to hear. When it comes to Black people and creating Black organizations or Black groups, they get funding. That basically maybe that is short. They'll get it as far as 5 years and it's done. There's nothing about there's nothing about retention. If you start something good, you create relationship, all of a sudden it's done. And so that's why a lot of community members, when there's research, when research is being brought into community, a lot of people don't want to interact with researchers just because they've done it all before. This has been done for years and years and years and years, where researchers come into community, they sell dreams to community members, and then they disappear. There's no results. There's no finding, right? And that's why I'm gonna put Ingrid out there. Ingrid did her research, and she would constantly nag people. Hey, about that research. What's happening? That's what we need to be doing. That's what we need to be doing. We got to be intentional. If we're gonna do something, if you tell community members that I'm gonna help you, they're gonna trust you and they're gonna hold you to that. Right. And so if you're not accountable, guess what's going to happen? Everyone else that comes behind you, they're not going to trust. So I'm not going to hit that too much. The next thing I want to talk about too is this. There's a disorder. It's noticed in the US, but it's not noticed in Canada. But we've heard about it. It's called post-traumatic slave syndrome. As providers, we need to know what it is. Right? We need to know what it is as providers, especially white providers. What is post-traumatic slave syndrome, right? Or / multi-generational trauma. What is multi-generational trauma? How does it affect the African Nova Scotian community? So I would say for the white providers, knowing a little bit, you don't have to know everything. Know a little bit about the community, about the people in the community you are dealing with. That's it. Thanks, everyone.
Thank you, Mariel. Thank you so much. Okay, so we can pass it on to Nadia for some Q&A. Thank you so much.
Hi. So yes, I'm actually trying to add spotlights so that we can all be joined together in a conversation. And we want to invite people to talk a little bit about some questions. There's lots of great resources that were shared in the chat. Here's a question about representation and whether language is a barrier. So for example, if someone describes their distress as a reaction to managing white supremacy rather than depression, That question kind of got lost, but I think we can probably think about just the way we name and identify concerns. I see Dr. Waldron nodding her head, so I wonder whether that means she would like to field this question.
Yeah. When I was doing my doctoral work, I focused specifically on psychiatry, the problems with the psychiatric system, the problems with how they diagnose Black people, labeling, which is still an issue in psychiatry. And I came across this term called somaticization because of the deep taboo that Black people have around mental illness. They are often hesitant to talk about the fact that they're depressed or they have psychosis. So they tend to use their bodies as a way to express mental health concerns. So if they're depressed, they may say, my stomach is hurting me. You know, the somaticization is the body, right? And it's using your body to express illness where the illness is really mental health issues, but because of the taboo, you're not outright talking about that. You're using your body to communicate that. And then also using terms like I have the blues, which is very much African American, not really hitting the point, getting to the point that actually I am depressed. So I think language is really important when you look at communities like Black communities that have considerable taboo around mental illness, and that they tend to use other terms that may seem not as serious to describe very serious mental illnesses. And that, of course, shapes how people are labeled, and that shapes the ways in which psychiatrists and other mental health professionals actually come up with diagnoses for Black people, which could be a misdiagnosis, which often happens, or an underdiagnosis. And the studies also indicate that Black people tend to be overdiagnosed with schizophrenia and underdiagnosed with affective disorders like anxiety and depression. Studies, when I was doing my PhD, that's what I found. That was a long time ago, but that was clear in the United States and in Britain. And we know that schizophrenia is seen as extremely pathological and is seen and perceived as dangerous. So the worst illness that you can have is schizophrenia. And of course, when you look at the Black body, Black people are seen, particularly Black men, as dangerous and particularly pathological. So the intersection of Blackness and mental illness often results in diagnoses that actually reflect our perceptions or stereotypes about mental illness on the one hand and about the Black body on the other hand. So I think labeling is a very interesting issue, and it goes back to cultural competence. If you don't have an understanding about the ways in which Black people like to express and verbalize experiences with mental illness, sometimes through their bodies by saying my back hurts, my stomach hurts, not really getting to the point, then you will miss a lot. And then you could certainly misdiagnose and underdiagnose people, which of course is extremely risky. So that's what I would say about that. But it obviously comes back to cultural competence. It comes back to working with communities that you haven't worked with before and getting to know them and to understand them and being educated. So you understand the cultural talk in those communities, how they understand and express issues and concerns.
Also, even to finish off what Ingrid is saying too as well, a lot of within the last 2 years, I would say we had tons more individuals of African ancestries being admitted into forensic, the Abilene and all these mental health hospitals. What's happening now is the educational component is now, I would say, is missing, because a lot of these individuals are being diagnosed. And, when it comes to the family or, trying to educate the family, it's like, they're so confused. Spirituality plays a big part in this as well, that both me and Ingrid didn't mention earlier, but especially in our Black community, spirituality is up there. And so sometimes too, a lot, like for instance, working with some African families, they would just say if an individual was diagnosed with schizophrenia or whatever, the first thing they would say is it's the devil.
Yes.
And and so that educational component is so important, so that, hey, okay, your son, daughter was diagnosed with this particular illness. or this disorder, here are some things, here's some resources, here are people you can talk to, here's some information that you can read on yourself. If you have any other questions, come back and stuff, right? But that's something that I would say is missing, right? Whereas the individual is already being diagnosed, and now like the family is not, they don't know what to do, right? So I do agree with Ingrid on that.
I think there's probably so much more that we could dive into, and there's some great questions and resources and comments in the chat as well. This is a much larger conversation in terms of all of these things, both in terms of how do we build safety and trust so that people can share and be heard appropriately and get diagnosed appropriately, and how do we build understanding and trust in the communities in order to help build more support for any kind of treatment plan. And then, you know, Dr. Waldron, you shared some really interesting comments about the importance of Black religious leaders being trained specifically in order to be able to provide competent support. So there's a lot of work on many different levels that needs to be done. And this was just a short lunch period, 12:56. So we're probably running out of time, but hopefully everyone is going to join us tomorrow, where we're going to be talking about an Afrocentric approach to social work and the importance of beginning that. This is part of much larger work. For example, we just started requiring this year specific training in cultural competence, anti-racism, anti-discrimination. So stay tuned, because we're going to try to provide information on lots of things, including post-slavery traumatic syndrome and the importance of looking at intergenerational trauma. There is, as Jody said, so much reading to do now, and also so much more research that needs to be done around how this impacts Canadians, because obviously the Canadian story is different than the American story, and then the Nova Scotian story is different. So thank you all so much for leading us in this conversation that is the beginning of many more conversations. It certainly highlights what our Social Justice Committee is trying to point out, which is the ways in which there's a much larger context to mental health. And we have to rethink service provision. We have to rethink who's providing the services, all of the policy. There's so many areas of work that you identified. I could not possibly summarize them all. Juanita, thank you so very much for organizing this panel on behalf of our Social Justice Committee and getting such amazing, insightful, and thought-provoking speakers. And we hope to see everyone tomorrow for lunch. Thank you all so much.
Thank you.
Have a great day, guys. Bless you.
Bye, Mario. Bye, everyone.